Hello, everyone, and thank you so much for joining us this evening for another educational webinar. My name is Michael York, and I will be your moderator for this evening. If at any point you do have any questions during tonight's webinar, go ahead and try to hold on to those until the end, where we will open it up for a question and answer segment. Sometimes the questions will be answered throughout tonight's presentation, especially with Dr. Wang at the helm, as she is very, very intricate and will have a lot of great information for you and probably answer some of those questions you already have bubbling up to the surface. So we are very excited that we have our first patient webinar of the year, and it is hosted by Dr. Elaine Wang, and it is entitled New Year's Glaucoma Resolutions. And it's a wonderful topic, and we're so glad that Dr. Wang is here to present it. A little bit about Dr. Wang. She attended the University of Rochester, where she received her undergrad degree, after which she received her medical degree from Duke University. She then conducted her ophthalmology residency at the Stein Eye Institute at UCLA, and then moved across the country to complete her glaucoma fellowship at the world-renowned Bascom Palmer Eye Institute at the University of Miami. So she's got both coasts covered there with regard to her studies and her fellowship and her residency. So we are obviously very thankful to have her here with us, not only tonight, but as a part of the Harvard Eye team. And without any further ado, I will pass things along to the aforementioned Dr. Wang.
Thank you, Michael, for this very generous introduction, and good evening, everyone. Thank you for your time to spend this hour with us the beginning of the year to learn a little bit more about glaucoma. Happy New Year. For those of you who are celebrating Lunar New Year, it's coming up soon, so happy Year Dragon also. January is the month of glaucoma. We call that Glaucoma Awareness Month. So that's why I always start off the year by telling you a little bit more of what we know about glaucoma, how we treat it, and that's going to be the focus of today's topic as well, is to give you a little bit review slash preview of some of the newly approved devices and medications that we can use to treat glaucoma in this year 2024. In fact, because it's the month of glaucoma awareness, the American Glaucoma Society throughout the month has put out good patient resource information on what is glaucoma, basics about glaucoma, symptoms of a glaucoma, and the current existing treatment. It's on their website. I'm going to have Erica and Michael be in charge of sending out emails to our patients with glaucoma, where you could click on the links and read more about glaucoma if you'd like to. So glaucoma, as most of you, I assume, would be patients with glaucoma or who have family members who are worried about maybe they would have glaucoma, somewhat familiar about this topic. But just to refresh our memory, glaucoma is a leading cause of irreversible blindness, especially for people who are over the age of 60. Unlike cataract, which is something we do surgery to completely cure, glaucoma is not something we can just remove. I often have patients asking me, why couldn't you just take it out? Unfortunately, glaucoma is a nerve issue. It's a nerve glaucoma. It's a nerve disease change that is not a mass like a tumor or like a cataract we can remove physically. So what we do is to manage the disease and hopefully live with it in a way that it doesn't continue to cause permanent and detrimental vision changes. Like I said, blindness from glaucoma can often be prevented if you go to your doctors for screening with early detection and the appropriate treatment. We're oftentimes very successful in keeping glaucoma at where it is and not having it progressed. But without appropriate diagnosis and treatment, blindness can be one of the worst, the worst type of problems you get with glaucoma is you lose your sight completely. And that's not something we want for any of our patients. So I encourage you, if you don't know, if you don't think you have glaucoma, you go to your optometrist or ophthalmologist for your yearly exam. You asked about your risk of glaucoma. If you were told you probably were at risk for glaucoma, we want you to continue the monitoring of your glaucoma, make sure it's controlled. Just to briefly talk about what glaucoma is, we all know when you go have your glaucoma screening or management, tension check, pressure check exams, we often check your eye pressure. So glaucoma is a issue with eye pressure buildup. The eye constantly makes a healthy aqueous fluid, and that fluid is full of nutrition, just like the blood for the rest of the body. Aqueous fluid is the blood for the eye. It basically is transparent in color, however, but it does contain so much nutrition. It circles through the eye and provide that nutrition for the rest of the eye. Our healthy eye constantly makes this fluid on its own, and it also has a very delicate, intricate system that's built in to drain the used fluid to make room for the new ones to come. However, if you somehow have issue with that whole drain flow system, then you can potentially get into a situation where the drain is clogged and you have a buildup of the old aqueous fluid while the new ones are still being made. So you can imagine a buildup fluid causing high pressure. And that high pressure is going to cause damage to a structure that connects the back of the eye to the brain, namely the optic nerve. That optic nerve is a nerve. It's one of the thicker nerves made of millions, literally 1.4 million nerve fibers, making that big, thick nerve that's connecting the eye and the brain, the two essential parts of the visual system. And if the pressure in the eye is too high, that nerve can be damaged to an extent where it starts to cause trouble in the vision. When we describe thinning or weakening or worsening of the optic nerve or damage to the optic nerve, some of you may heard the word cup to disc ratio, or cupping, that one of your doctors might have told you at one point. The cup is a location within the nerve. The nerve structure normally is like a donut. So the donut has the actual donut part, the rim, and also a hole in the middle. That hole in the middle exists in the nerve as well. So that hole allows vessels from the body to come into the eye to supply the eye with blood. Around the hole are actually those nerve fibers making the bundle. So if you keep the whole volume or the size of the donut unchanged, if you enlarge the middle of the hole, like making the hole bigger and bigger, it's another way of getting rid of the actual donut part or the bread part of the donut. So that process is called cupping. That's another way of describing the cup is getting bigger, or the hole in the middle is getting bigger, as in the nerve fibers are getting less and less, so in nerve damage. If this is an example of a normal visual field, if you have glaucoma, most likely you've done a test like this. Even if you have not gone to the glaucoma specialist for a comprehensive visual field mapping, some of you might have gotten a screening version at the optometrist's office where they either give you blinking lights or squiggly lines where you're supposed to click a button to say, oh, I saw that. And that's called the visual field test. That test is not necessarily checking how well you see, but it's designed to check how extensive you could see to the sides or top or bottom, or in other words, the periphery of the vision. If everything looks good, it should look like the example I'm showing you right here on the slide. We all have natural blind spot on each eye. So the natural blind spot is where right over your shoulder, you know, when we're driving, people always remind you to look over your shoulder when you merge, make sure nothing's hiding in that blind spot. That is our actual existing physical blind spot that everybody should have. So on the test, I'm looking for those natural blind spots, but beyond that, there shouldn't be any additional blind spots showing up. These are what blind spots can show up as, these gray shadows that you see initially as a mild stage glaucoma. Another example of a milder stage of glaucoma where the shadow in this particular case is at the bottom, but you can see as time goes by, the bottom shadow becomes thicker. It gets closer to the center of this cross, which is the center of the vision. And on the right-hand side, you can see also a progression of the loss of vision, where initially the edges have shadow, then the shadows become darker in color and closer to the center of the vision, and eventually it gets really to the center of the vision. This is in severe form of glaucoma, where your center clarity of the vision can be damaged. So I'm going to show you in real world situation. In a normal vision, you see the center statue, you see the people in the middle, you see all the flags and the trees on the edges of the picture as well, as shown in this normal vision example. Early glaucoma starts to build shadows on the very far edges of the picture or image. And then if you get to advanced glaucoma and end stage glaucoma, that's when we call that tunnel vision. So this really shows despite having significant challenge in the periphery of the vision, all the existing flags and trees, what have you, you can't see them anymore. but the center satchel as well as the pupil are still looking pretty sharp to you. So glaucoma can be very deceiving. Up to the very end stage of glaucoma, you can theoretically still see 20/20 in the middle. And that's usually how we, on an everyday basis, gauge how well we can see. I can't tell you how many times when I talk to a patient about their risk of glaucoma, they always say, but I can see fine. You're absolutely correct. You can see totally fine, even up to the severe stage of glaucoma in the center of the vision. But the edge of the vision, you don't even know you're missing because we're so used to just turning our heads to see things on the side without knowing that the peripheral vision is actually gone. So some other examples of how damages can happen in glaucoma is that what I showed you in the previous slide, the progression of it is a classic textbook way. If everything follows the rules, it should be, the progression should be like that from the edges to the middle. But there's always an exception to the rule where in certain cases you can see black patches, gray area, or just distorted visions in the periphery or in the center that can still be some various little low frequency but potential still variations of glaucoma. And speaking of the types of glaucoma, in general, we group them into primary open-angle glaucoma, where within that, if you're not glaucoma yet, we just suspect that you have higher risk of developing it eventually. We call you glaucoma suspect. And opposite to open angle, we also have narrow angle glaucoma, which is a subtype of glaucoma that tend to happen more in Asian ethnicity. And then after that, there's secondary glaucoma, where the glaucoma could be a result of other eye diseases like chronic inflammation, like repeated eye surgeries, for example, to repair retinal detachment. It can be from trauma. It can also be long-term steroid use that increase your eye pressure. So there are other eye disease or even systemic problems like rheumatoid arthritis, like lupus, other autoimmune conditions, thyroid eye problems that could cause glaucoma. So we lump all of that into secondary glaucoma. Today, when I'm talking to you about the treatment options for glaucoma, it's mainly focused on primary open-angle glaucoma, which is the bread and butter type, the most common type of glaucoma, at least in the United States. So when we treat glaucoma, if you're on a glaucoma treatment, you know, most doctors, especially traditionally, we start someone on an eye drop. And if one drop doesn't work, we move on to the second drop, then we increase the frequency of the drop. I literally have patients on 5 different drops on different regimens for each eye. So when you're at that stage, you can really see yourself applying drops almost all day long, which can be really painful in terms of trying to keep the schedule. And also it does irritate the eye and it causes sometimes allergies, other times just blurry vision temporarily. It's just hard to manage when it gets to an out of control number of drops. Beyond that, we also have laser treatment options for glaucoma. And that laser are both lasers I'm going to talk to you about a little bit are non-invasive forms. And one of them can be equivalent to using eye drops nowadays, given new clinical results. After the laser treatment, which again is done less invasive or non-invasive, we also have slightly more invasive surgeries called micro-incisional glaucoma surgeries that oftentimes are combined with your cataract surgery. And once all of these less invasive options are exhausted, then we move on to the traditional glaucoma surgery, which understandably are more invasive because they're considered bigger guns to try to control the eye pressure. I'm not going there today. We're focused on some of the less invasive but more available ways of treating glaucoma with newer data that I can show you to support the use of it. The first laser I'm talking about is called the selective laser trabeculoplasty, or SLT laser. This is a non-invasive, safe, and effective laser that we often do in the office. So when you come in for a treatment for SLT, it's like an office visit. You don't have to worry about anesthesia. You don't even sometimes have to worry about having a ride because most people just drive themselves and go home with no issue. Your vision is not expected to really change. Other than slightly longer appointment, it doesn't differ too much from having an office visit. So I talked to you about how glaucoma happens is because the drain angle in the eye, the drain system can be clogged up or somehow not working efficiently to drain the fluid in the eye, causing a backup of the aqueous fluid, then leads to high pressure. This laser targets the drain of the eye instead of actually making a new drain, which in some people's mind, that's what laser does, is to burn things or create wound. This laser is designed so that the wavelength of the laser only send heat energy to the eye. And that energy is absorbed at a cell level, and these pump cells lining the drain is rejuvenized and reorganized on a cellular level, where it starts to wake up and work a little harder, draining the fluid. And these work much better in milder diseases. So when you're first diagnosed with mild to moderate glaucoma, SLT laser is your friend. The lasers has been around for many, many years, or over 50 years, and it has gone through several rounds of revolution where it's really becoming less and less invasive. And one of the more recent studies out of Europe actually proved that when we compare using laser to treat glaucoma as the first line, which means you're fresh diagnosed with glaucoma, you have not been on any eye drops, and we're treating your glaucoma just by laser alone, versus the opposite, where you're fresh diagnosed glaucoma, have never been treated in any other way, we're starting eye drops. So we're comparing these groups hand in hand. And the comparison result is that if you were laser, fresh off the bat, already laser, without trying drops first, you actually outperform the group that started on drops. So this really gives glaucoma specialists new hope in delivering treatment for glaucoma without having to use eye drops. Using eye drops is not bad. I'm not trying to tell you that everyone should choose laser versus drops. But a lot of the times, lifestyle and the fact that can you tolerate the eye drops? Are you having a lot of dry eye issue, irritation, blurry vision? Sometimes I have patients complaining that the bottles of the drops are so hard that they just can't squeeze drops out enough, accurately enough to be reassured that they had the drops in their eye. All those what you think might be minor issues actually play an important role in your decision of choosing drops versus laser. Since the laser is proving to be very effective and safe, I say if you have any concerns of using the drops, considering laser is really not a bad idea, especially if you're young, fresh diagnosed, have a busy lifestyle, laser is your friend. Anecdotally, and also based on other similar clinical trials, our glaucoma specialist has agreed that around 6.5 to 7 years is the average duration of how one single SLT treatment can last you by controlling your pressure still at an adequate level without having to use any additional agent on top of the laser treatment. This is what a laser looks like at Harvard Eye. It's literally what you encounter when you're being treated at Harvard Eye with the SLT laser. You can, this right here is the laser. It looks very much like the machine we check your pressure with. The chair is the exact same as your exam chair. You sit in the chair, the doctor sit opposite. I'm looking through the microscope, delivering the laser. No pain that you should be expecting. The only thing I warn people is that right after your laser, we do keep you for 30 minutes to check your pressure to make sure there's no pressure spikes right after the laser. And if there were, we treat it right there with eye drops. Then we send you home. Some irritation and inflammation, kind of feel like my eyes a little inflamed. Light sensitivity is expected for the next couple of days. But then for the most part, there shouldn't be any pain or irritation from the laser. Luckily, we're still enrolling new patients into our National Eye Institute ran SLT clinical trial. This is the trial, this is the COAST trial. And then we've been enrolling patients as part of this National Eye Institute effort in the past 2-3 years, starting 2022. And we've recruited couple dozen, close to 30 people into the study. And we're actually the #1 recruiting site in the entire country, along with other very renowned eye institute like Mass Eye and Ear at Harvard, or Johns Hopkins, or Pittsburgh University. All the university centers are also, a lot of them are part of this. But in Southern California, we're actually the only site that's been selected to participate in this trial. This trial focused on looking at the SLT laser I just told you about, but specifically only looking for patients who are newly diagnosed. So if you've already been treated in the past, even if it means you've treated for a week and then you didn't like the drops, unfortunately, you don't qualify for the trial. But if you are interested in getting the trial, you have never been treated, but you think you have high risk or have developed glaucoma or are told that you may have high pressure, this might be a trial you want to be enrolled in, because we are, as glaucoma specialists, are very motivated to see what is the safest way to conduct the SLT laser. What's the lowest possible level of energy we can give to people to make sure everything is safe to the best extent, but also effective. So that's the goal of this trial. Like I said, we're only looking for people who are newly diagnosed with borderline glaucoma, suspicious glaucoma, high eye pressure, or very mild to moderate changes in glaucoma. So if you know you are, or a friend or family member who might fall into these categories, you're more than welcome to visit one of our optometrists or your own optometrist to have them decide whether you'll be a good referee to send to us, or you can just come to us for screening as well. In summary, laser trabeculoplasty, or SLT, is a very safe and effective procedure that we do to lower eye pressure. It's only appropriate, though, for open-angle glaucoma, like I told you at the beginning. It can be repeated if the first laser wears off over time, which means that it does wear off. Like I said, on average, it's about 6.5 to 7 years. So after that, it's a fair game if the effect of it wears off. But the good news is you can still repeat the laser. And the side effects are very mild and rare, and usually happens right after the laser. There's no long-term lingering effect from that. Along the same lines of laser, another laser that's one of the newer treatment also, it's called the micropulse TLT, or some people still call it CPC, scleral laser therapy, is another laser that we offer at Harvard Eye, and as one of the a very non-invasive laser that we use to treat glaucoma. And it's for all stages of glaucoma. Unlike the SLT, which targets more milder form of glaucoma, micropulse can be done for any stages of glaucoma, and beyond open-angle glaucoma, it can also be done in people who are not open-angle, but other various types of glaucoma. It's safe and effective, and it has also pretty long-lasting effect. It's newer, so we don't know going like beyond 5 years is still super effective. It can wear off. We've seen people effect of this laser wearing off, but it's very well worth it if you really need a break from using a lot of the eye drops, you have busy lifestyle, important life events where it would prevent you from faithfully using eye drops. If your doctor told you you ultimately need the more invasive glaucoma surgery, but for some reason you're taking care of your family member, you have a long international trip that you plan for months, this might be a good choice where it can bridge a gap between now until you can get the definitive surgery. So something to consider. This is a picture of the actual laser unit. It's like a little box, and the purple little probe is the probe we use. As you can tell, there's nothing sharp about the probe. It's a like little foot plate that sits just hovering the surface of the eye on the white part of the eye, and does windshield wiping movement with the the surgeon would do that with the little probe. So there's nothing sharp or penetrating the eye. Again, in this specific type of laser is also the heat energy going into the eye to help facilitate the drain, and also to some degree reduce the production of the aqueous, so there is no backup issue in the eye. These are real life pictures of us using the laser probe. So you see we use a little Q-tip to kind of help manipulate the eye to direct it in different directions, and use the purple probe to actually deliver the laser. So when patients are under mild anesthesia, unlike the SLT, this process is done in the operating room, and we do have anesthesia there to monitor, mainly because it can be a little bit more uncomfortable while the laser is going, but you're under sedation and there is no pain. You should be asleep when we're doing this. It's a short process, about 5 minutes, so quickly you wake up and you don't remember what you gone through. How well does it work is probably the most important question you ask. it can achieve a reduction in pressure anywhere from 30 to 45%, which is very, very good. On average, I'm still great response within the first year. After the first year, I'm starting to see the wearing off of the effect. But the good news about this laser is, again, you can repeat it. Up to 72 months, though. So that's about 6 years again. And during the 6 years, people can get up to 3 treatments to maintain how well their pressure is reduced. And on top of making sure the pressure is good, it also reduces the number of medications in an eye, and including oral medications. Some of the patients with severe forms of glaucoma, unfortunately, we have to put them on oral medications to reduce their pressure. And it does, it also compared to other glaucoma surgeries, more invasive things that requires like sharp opening of the eye and may have risk of bleeding and infection. This particular surgery or laser procedure has very limited follow-up appointments. So that also, again, makes lifestyle-wise concerns a little easier. And the recovery is very good compared to other actual surgery. You don't have any limitations on what you can do. You can still go to the swimming pool. You can still go to the spa. You can also put on eye makeup. You can still go to work. You can still do lifting. So no real restriction on physical activity. So that's another really, really good side for people who are young and working and may have travel plans. And it also leaves other surgical treatment options wide open in the future, should we really get to the point where we have to cross that bridge of doing more invasive surgery. So in summary, MicroPulse is another very safe and effective laser procedure. It is appropriate to be done in not only open angle, but various other types of glaucoma to lower eye pressure. Can be repeated, just like the SLT. And the advantage of this one is also that instead of only treating early stages of glaucoma, this laser can target more severe, advanced, and even end-stage glaucoma, where people are really on the borderline of needing invasive surgeries. Speaking of surgeries, beyond non-invasive lasers, we also have micro-incisional glaucoma surgeries available. So what do we expect with micro-incisional glaucoma surgery? I think they name it this way to almost like putting a disclaimer on it that these are not the same as your big gun cutting glaucoma invasive surgery. They're micro-incisional. They're mostly done at the time of the cataract surgery. So they're not expected to be lowering your eye pressure to an extent that your glaucoma, quote, is cured. And if you were on 5 different drops, this micro-incisional surgery is not going to just miraculously remove all of those drops for you and you somehow have stable glaucoma going forward. So these are targeting also more milder diseases of glaucoma. And they can be, the vast majority of these procedures require that you also get a cataract surgery at the same time. In other words, these are tag-along procedures. They're not standalone. We do have the good news about part of today's talk is that we have some standalone options coming already approved as within this mixed procedure category. So that's really something good for people who thought they missed the boat of doing mix at their time of cataract surgery when mix weren't even a big thing when they had their cataract surgery. So in general, the mixed procedure are grouped into 2 groups. The first group is where we leave a little device behind. So we leave a little stent behind. Some of my patients, or most of my patients, probably heard of either the iStent or the Hydra stent. And these are stents that's left in the drain angle, the tubing, the actual tubing of the drain, where it's like working like the heart stents. If you have family members yourself had heart blocks, they put stents in there to keep the vessels of the heart open. And this idea is very similar, where we put the stent in the tubing of the drain angle to make sure the lumen is open and fluid can flow through to allow drainage of the fluid to lower pressure. So these are the 2 main types. This is first generation iStent, which is no longer being produced. We're focusing on the later generations, the iStent inject or W inject. These are stents like little thumbnails you put in there. I'm having pictures, a side view of the thumbnail pushed into the drain, and also an intraoperative view of the 2 little thumbnails pushed into the angle. And this is the hydrous stent, where you see intraoperatively how it sits horizontally, kind of really just lining the lumen of that 360 drain tube inside the eye. These are the two types of already available stents that I very commonly offer to my patients at time of their cataract surgery. iDose is the newly FDA approved stent. It's not only a stent, it contains medication in it. It contains the PGA, which is a fancy way of describing the whole category of medication you use at night. A lot of you guys on the early stage of glaucoma use latanoprost, Xalatan, Travatan, Xioptan. So all those prostaglandin analog medications, and Lumigan is another one, are medications that you use 1 drop at night in each eye to lower pressure. So it contains that category of medication within the stent. So instead of you applying the drop, it's like a depot of slow release of the same medication inside the eye. The idea is at the time of your cataract surgery, we can put it in, and later on, once the medication wears off, just like any depot of any sort, may it be a patch or a little something they do under the skin that implant in the body for other systemic issues, this also contains a limited amount of medication that lasts, now they say, up to 18, 24 months. And after that, what do? You actually do another surgery, very minor, take it out and put another new one in. I think that's the plan. Since it's so new, we don't really know how insurance would play out with this and how exactly we're going to deal with it. But the idea is that it's exchangeable. We can either leave the old one in there. It's made with metals that's not expected to really cause any inflammation or allergic reaction. We leave it in there, put a new one in, or some thoughts it's like we can take it out and put a new one in. So that's an intraoperative view of what it looks like, very much like the iStent. It's actually a newer generation of the iStent where it just contains medication in it. So this is just some boring math to show you compared to drops, which are gold standard as compared to the oldest glaucoma eye drop ever made, Timolol, how well that works. So it turns out on average, the iStent also reduces eye pressure by around 30% also, which is the gold standard from Timolol. And in an absolute number, it's about 8 points in your eye pressure measurement. And that is sustained even 12 months out from the initial implantation of this iDose. So that's a new thing that literally was just approved last month, and it was at the end of last year. So now the company is still working on getting this onto the market and how get insurance coverage and all of that. It's not quite ready to be commercially completely rolled out yet, but I foresee this in the next coming few months that it'll be able to be covered by the insurance and something we can offer you guys. So this is similar to another device or implantation some of you might get called the Durista. So that is a little pellet of medication that we just shoot into with a little injector into the eye, and it's technically free floating within the front part of the eye. Usually it doesn't, it settles into the bottom and it sits there, but it's not plugged into any structure. But this device is actually plugged into the structure and done at the time of cataract surgery. Another group of minimally invasive glaucoma surgery does not leave any stents behind. So the first group we talked about left the stents behind, the iStent, the hydrous stent, and the iDose stent I just told you about, that's new. And the newer, the second group of mixed procedure does not leave any stent behind. So the process of that is to remove, the idea of these group of procedure is to remove any clots or scar tissue that's lining the tubing or the roof of the tubing that's in charge of the drain. So may it be a catheter you use, a little blade you use, a hook you use, the whole idea is to shave off the scar tissue or the roof of the tubing, making it an open lumen so everything can flow through without having to encounter any friction or resistance. So some of it is done with the hook, others with the blade, and some catheters can be used to achieve the same goal. So all of these procedures I just told you about, technically, just before the end of last year are still fully required to be done at the time of cataract surgery. And the thinking behind that is we want to ensure the highest amount of safety. And that level of safety is to minimize the number of anesthesia you have to go through, minimize the timing in the surgery, minimize risk of infection and bleeding. The more times of surgery you do, the more chances, the higher the chance that something bad may happen. So they're only required to be done at the time when you're getting another surgery anyway, which is the cataract surgery. So some people might think they missed the boat, the MIGS boat, when they already had their cataract surgery done years ago. More recently, at the end of last year, iStent Infinite is another device that's approved. And this basically is a fancy way of describing iStent, which I showed you earlier, like the little thumbnail that are implanted into the eye 3 at a time. So there, instead of 1 or 2 thumbnails, there are 3 of them trying to cover a larger area of the drainage angle. This process and this procedure can be done in eyes that's already gotten cataract removed as a standalone procedure. And the company have actually been working really hard, gone through the hoops of getting insurance on board. So more and more, this is an insurance covered procedure. So if you're someone who's got cataract taken out, been using 1 or 2 or more than that drops, have had surgery done in the past for glaucoma. It could be minimally surgery, it could be laser surgery, it could also be major glaucoma incisional surgery, and failed those, and they're not supporting where your pressure needs to be, you need additional something to be done. This procedure is now approved to be done in people like that. So in addition to this iStent Infinite, the other catheter procedures I showed you earlier, where it doesn't involve leaving any stent behind and only using the equipments to remove the scarring in the angle, are still available as a standalone procedure as well. So now it just makes it possible to combine the two, both removing the scar and leave stent in the eye as a standalone procedure, even in those people without cataracts in their eye already. It had always been an option in people where their cataract is still there and we're doing cataract surgery. And now it just became more available to patients who kind of already had their cataract removed or didn't think of it or didn't want it at the time of their cataract surgery. So it's really good times now in terms of treating glaucoma. There's so many varieties of options that we can do. So yeah, this is what I told you about, where it's still available after cataract surgery. So in summary, these mixed procedures are very safe and effective. It can be in a lot of my patients where they have mild to moderate stage of glaucoma, we are able to almost, fingers crossed, remove all of their drops, but at least to reduce the number of drops from 2 to 1 to 3 to 1. Usually they're on, if they have to be on some drops, it's after these procedures, usually 1 drop. And again, it targets more of the milder diseases from mild to moderate cases. And it helps to delay more major glaucoma surgeries, especially in severe cases of glaucoma. So again, putting everything together, we talked about today, we talked a lot about the dropless options in this new era of treating glaucoma, the SLT laser, office procedure, non-invasive. We have an ongoing clinical trial that's actively recruiting patients who are freshly diagnosed with glaucoma. Micropulse laser is done in the operating room. It's non-invasive. It's done under anesthesia. It targets all stages of glaucoma, all types of glaucoma, and so something to consider for everybody. Mixed with cataract surgery, there's the stents, and there's the goniotomy or the removing scar procedure that can be done, and the newly approved stent that contains the medication in it. And then finally, if you're already finished cataract surgery and you want something to help with the burden of medication or just want to get rid of your medication altogether, you have newly approved stents available, the iStent Infinite, as well as the previous scar removing process or the goniotomy, trabeculotomy procedure is still available for you. And that's all I have for tonight. And I'm happy to take any of your questions at this point.
Yeah, thank you so much, Dr. Wang. We really greatly appreciate it. And at this moment, like you just said, we will open it up for a question and answer segment. So you can submit those questions just using the Q&A function down below, or you can use the chat. Either or works. Also, if you're like me and you are just overwhelmed with all the great information provided, we will be sending out a link with the entire presentation, the entire video to it. So you are able to go back, rewatch it. If you have friends or family or loved ones that you're like, oh, I think they actually have glaucoma as well, this would be interesting for them to know as well. You can go ahead and share it with them that way. It also will be available on our YouTube page as well in the next week or so. So you will be able to access it in all three of those different locations. So we will go ahead and open up the question and answer function. And this is actually just a great common question to know. What is your ideal goal eye pressure, just as a standard patient?
That's a perfect question. I love that question, and I wish I have a uniform answer for that. You can't imagine how sometimes frustrated I get when people tell me my pressure's 20, as long as it's under 21, isn't that okay? You're absolutely correct. In normal, no issue with glaucoma, healthy young eyes, we say your eye pressure can go anywhere between 10 and 21. And as long as you're within that range, even if you're 20 and a half and 21, you're fine. However, things are different when you already have glaucoma. I like to remind people that glaucoma is an issue of the nerve. So the nerve gets thinner with high pressure. You have glaucoma because your nerve is thin. Not so much about your pressure absolute number, it's the fact that you have nerve damage. That's what qualifies you as glaucoma, not the pressure. So now you have a nerve that's already thinner. If you're trying to break a really thick stick, it takes a lot of effort. If your stick is pretty thin, it takes much less effort to break that. So to that analogy, whenever you have glaucoma, the more nerve damage you have, the less your eye pressure needs to be. So depending on the severity of glaucoma, again, severity of glaucoma is graded more by the level of nerve damage and vision damage, not graded by how high your eye pressure is. So if your nerve damage is severe, then you probably cannot sustain even a pressure of 15. If your nerve damage is miniature, it's only a tiny little bit, then maybe 18 is good enough for you. So it's not a uniform answer for anyone. It depends on the severity of your problem. In general, the more mild your glaucoma is, the higher your pressure can be. The more severe your glaucoma is, the much, much lower your eye pressure needs to be. I hope that answers the question.
Yeah, a very good question, and not a straight answer for every different individual. It's very much so on a patient to patient basis. So, would you mind describe? Oh, sorry, go ahead.
No, I saw the pressure,
Yeah.
the question. Durista. Yeah, Durista is a medication implant. It's a little pellet containing the PGA medication also. It's contained in a little injector, like a little needle injector. It goes into your eye, the front part of the eye. It's also a process that we do in the operating room, just make sure everybody is safe and calm. Not everyone, is very all calm about a needle coming to their eye. It comes to the side of the eye, the surgeon stands right next to you, and that little needle literally delivers that going into your eye quickly, like a second, in and out, and kind of push the pellet into the eye. And that little medication pellet stays in the eye, everything else is removed. We give you antibiotics to make sure you don't catch an infection afterwards. That's the extent of it. Problem with Durista is, as of now, the company is actively working on additional indications, but as of now, Durista is only approved for one injection per lifetime per individual, which is not the ideal situation. And on the clinical results, on the data we collected or they collected during the clinical trial, on average, each pellet works about 4 months. And there are other people who have it work less than that. But we've seen some people have the effect lasting up to 2 years. So no one really knows whose pressure is going to be what after the injection. So you still need to have follow-up after that pellet is delivered to your eye. More importantly, though, you cannot get a second injection unless I think you go out of insurance and ask to have it done cash if it's working well for you.
How do you determine the level of nerve damage?
Yeah, you cannot do that at home. It's something we do in during your visits. You know, every time you come in for your glaucoma appointment, you have your pressure checked with no doubt. You also have scans of your nerve. You have pictures taken of your eye. You have the peripheral vision test. So all the testing, ancillary testing we do, we put you through a machine. That's when we measure the nerve damage and the level of your peripheral vision damage.
And we have a question from somebody that, and it sounds like it might be a patient that might be able to join the COAST study depending on prior treatments. But is a person with a diagnosis of glaucoma suspect and a normal eye pressure a candidate for SLT laser treatment?
Yeah, that's a good question. Usually, it depends on the previous question. It's kind of going along with the previous question. It depends on where your eye pressure sits. If your eye pressure is determined to be at goal, you don't need further lowering of your eye pressure, even though you do carry risk of having glaucoma, then you don't need the SLT. If you're someone who call glaucoma, we call glaucoma suspect, and we need you to use eye drops to lower your eye pressure, then you might be a candidate to have the laser done to replace your drops. So it all depends on where your pressure is.
And please, if anybody does have any more questions, go ahead and submit them to our question and answer function down below and or the chat. Or if you are anything like me, and oftentimes I will have questions in the days following any informative information, you can always happily send it to us to the same email that was registered with. It's just marketing@harvardeye.com. And we are happy to take your questions there. Like I said, if they do come to mind in later days or this weekend, we are always happy to assist you with those questions. And we do have one more, and it sounds like if somebody has had a type of laser surgery a few years ago that was to open up the drainage and tear ducts, they said the canals and eye fluid were getting narrow, so they opened them back up to avoid future pressure. Does that sound like it was a glaucoma procedure?
Yeah, it sounds like a laser LPI or laser peripheral iridotomy procedure. It's done for narrow angle glaucoma if we're concerned that you may get into an acute attack where your pressure in the eye goes up really high. So it's not tonight. Unfortunately, tonight's conference topic does not cover the treatment for narrow angle glaucoma, which later on we can have a talk on that. But unfortunately, yeah, it is a laser. It sounds like a laser. It's not for tear drain. People always ask me, and I always tell them, glaucoma has nothing to do with your tear. The tear system is actually all surrounding the eyelid structures, and this aqueous fluid is within the eyeball itself. So they're not related. You did have a laser to open the drain, but not your tear drain.
Once you started with drops, is there a natural progression to like a worsening condition, or are drops safe for using specifically with glaucoma?
Yeah, so drops, they're always if I understand the question right, drops, the fact that you're on drops does not make it worse, and sometimes it's kind of a same similar situation where people think insulin make their diabetes worse. Like once they're on insulin, their diabetes actually got worse. That's not how it goes. It's usually when your diabetes is that bad that you start needing insulin, and that does not stop you from some of the complications of having bad diabetes. So drops is the same way. You use drops to lower the pressure. There's no guarantee that your glaucoma will not progress at that level, because the one thing you and I try real hard to stop but cannot is aging. Aging process always deteriorate all the functions inside the body and including the eye. So once the body decides that it's working too hard and draining those fluid in the eye, it gives up. Then no matter how much external force we give to it, we can only help to an extent, and maybe you require more and more drops over time, maybe leading to glaucoma. It all leading to glaucoma surgery. It all depends on how we call a slow progressor or fast progressor. Majority of glaucoma patients are slow progressors, where things happen over decades of time. But occasionally we do run into people who have severe and fast progression of their glaucoma, where their glaucoma get worse quickly despite being on treatment. And in those cases, we have to tap into surgery.
With regards to SLT, are there any side effects, and how many times can it be repeated?
Yeah, SLT doesn't have any long-term side effects. Immediately after the procedure, sometimes you can have a pressure spike where the pressure goes really high, which is why we keep you for 20 to 30 minutes after your procedure to make sure it doesn't happen. If the spike doesn't happen within that time frame, it's not likely to happen later on. And some irritations and light sensitivity, which is a sign of mild inflammation, which is something we actually induce. We wanted the eye to have. That's the rejuvenizing process, is inevitable. So people sometimes complain about a little irritation or nagging in their eye, which is you can just take some Tylenol for, but it usually is not long lasting, about a couple days, and then it gets better. And how many times it can be done is the second question. Yeah, in traditional way of doing the SLT, we like to repeat it once, and then once it fails again, we may offer you a second repeat, which would be the third time in total. If it still doesn't work at that point, we would declare you're not a good candidate. We won't do it again. However, the new study called the COAST study that we're recruiting now is specifically asking that question to say, if we do a lower energy treatment session, can we repeat that on an annual basis, regardless of where your pressure is? The idea behind that is we want to maintain, just like a car maintenance, right? You take your car for maintenance every 6 months or so, and it's not necessarily a car's broken, and you're taking it in for a checkup to do an oil change, to do an alignment, to make sure it continues to run smoothly. So the annual, regardless laser treatment, which means we repeat every year, there's no limitation on number of sessions we give, is trying to see if we do it that way, can we maintain the eye pressure better than just do it by when you need it.
Are there any certain medications that cause issues with glaucoma, such as like steroids or etc.?
Yeah, steroid use, especially those you apply locally to the eye, like in forms of creams or drops or around the face area close to the eye, and even nose inhalers, that's known to cause risk of increasing eye pressure. Not to everyone. You have to be, quote, a responder to get that kind of problem, which means if you're on those medications, you should have your pressure checked.
And then leading to that, how often should you get your pressure checked for glaucoma?
I usually suggest more frequent when you have severe disease. When you have mild to moderate disease, we do it every 4 months. And if you have more severe, every 2 to 3 months.
And then this will be our last question for the night. And does glaucoma affect both eyes equally?
Not necessarily. I've seen asymmetrical involvement. Usually both eyes are involved, but one eye slightly over the other is pretty common. Rarely we see one eye severe, the other one only a little bit. That's less frequent.
Well, fantastic. And we thank you so much to everybody for joining us this evening. And I guess before we sign off, Dr. Wang, any last words?
Yeah, so in the next couple of days, Michael and Erica will work on sending out an email to all of our patients at Harvard Eye to bring to your attention Glaucoma Awareness Month. And we're going to send out links to the American Glaucoma Society official website, where they have patient resource information on what is glaucoma. All the great questions you just asked me, you can probably find answers in those articles. So that'll be something to either read yourself or pass along to your family member that you know may need it. And like to wish everybody another happy new year. Stay healthy, stay away from glaucoma, do your drops, do whatever procedure and check up your doctors tell you to make sure your vision stays as healthy as it is. And yeah, so that's it. Thank you so much for your time tonight.
Yeah, thank you, everybody, and have a wonderful rest of your evening. And Dr. Wang, thank you so much for your time as well and the wonderful information.
No problem. Bye-bye, everyone.
Bye-bye.